This is out of your ward and history, Chapter 25, Caring for the Child with a GI Disorder. So the GI system, it's responsible for ingestion, digestion, absorption, metabolism, and elimination. The mouth, esophagus, and stomach is the upper portion of the GI system, and it's responsible for ingestion. Then the lower portion, which includes the small and large intestines, the rectum, and the anus, is responsible for digestion, absorption, and metabolism. And the large intestine takes care of the elimination. We have accessory structures. That is the liver, the gallbladder, and the pancreas. The liver metabolizes, and the gallbladder excretes and stores bile, and the pancreas produces enzymes that help metabolize, like our proteins, our fats, our carbs. The pancreas also produces insulin and glucagon to help our body keep a balance. So the development of the GI system according to age. So the infant needs frequent feedings. They're really developing that suck-swallow reflex. Solid foods can be introduced at about a year of age. The toddler. So the toddler gains about 5 to 6 pounds every year. And really at this time they have a decreased caloric need. They need about 102 kcals per kilogram versus the infant needing more. The toddler will get kind of picky with their foods. They might go on what we call like a food jag, which is like a food fad. Like they might only want to eat fruit or only want to eat cereal. The preschooler, at this time they're eating a whole range of food, but they're going to have an appetite fluctuation. So sometimes they're going to be really hungry where they're eating, you know, tons of food, and then there's going to be other times where they don't really want to touch anything. The school-age child, at this point their GI tract is stable. So it's the same size digestive system as an adult. They'll have stools that are formed, usually stools once a day. So structural GI disorders. The inguinal hernia. This is usually painless, and there'll be a lot of swelling extending toward or into the scrotum. It's, again, pretty common in males, especially those premature children. They might be more apparent when the child is crying or straining or coughing. So nursing care. So the treatment of choice is surgery. Usually the surgery is outpatient. So make sure you're just doing, you know, good education, pre-op and post-op. The umbilical hernia. So this is the most common type of hernia in infants. The majority of these hernias, the patient's asymptomatic. It's going to be more prominent when the infant is crying. You're going to see the soft midline swelling in the umbilical area. Some complications is that it can become strangulated. the nursing care, most resolve by itself by 3 to 5 years old. They may need surgery for larger hernias. They really don't have, there's not a whole lot of post-op complications. Just making sure, like, for post-op nursing care, that you're keeping the wound clean and dry, that you're managing the patient's pain. The child will have to have a dressing on for 48 hours after the surgery. They can resume a normal diet and a normal activity, but they should really avoid any strenuous activity for 2 to 3 weeks. So, anorectal malformation. This can be, the incidence is approximately 1 in 4,000. It's more common in males. They'll generally see it at birth. They can have rectal atresia, which is like a closure, or like a stenosis, where there's a narrowing of the passage. The patient or the infant will have some vomiting, abdominal distension. They'll have difficulty passing their stools. When they have the rectal atresia, since it's a complete obstruction, they're going to have surgery so that they could pass that stool. When they have the stenosis, their stools are like, they look like little ribbons, just very narrow and thin. So, nursing care, again, education, preparing the parents for surgery, post-op, pain control, watch for signs and symptoms of infection, do good hygiene care. The infant will have an NG tube. The oral feedings will start once peristalsis has began again and stools are passed. The patient, for discharge, you'll want to teach about colostomy care, so making sure that you're teaching the family about, watching for skin breakdown with the colostomy, prevention of infection, adequate fluids, adding fiber, stool softeners, and really make the parents aware that this may delay the potential of toilet training. So, obstructive GI disorders. Hypertrophic pyloric stenosis. So the cause is unknown. There's many different theories of what the cause is, but nothing definitive. It usually occurs in healthy male infants, but what will happen is they're going to get episodes of projectile vomiting after eating. So after the infant will feed and have this projectile vomiting, they'll want to eat again. They're going to have a lot of weight loss, dehydration, constipation. They might have, in an infant between 3 and 12 weeks, they might have an olive-shaped mass. So, nursing care, they're going to need a myotomy. And this is a laparoscopic surgery. It's a pretty successful surgery. So before surgery, the infant will be NPO. Post-op care, you're going to want to maintain their fluid and electrolytes. Watch the feedings after surgery, because the breastfeedings and formula can resume after 24 hours if clear liquids are tolerated. But if you're getting beyond 48 hours of the surgery and the infant is having that projectile vomiting again, then they're not tolerating their feedings. Intussesception. So this is a condition where the proximal end of the intestine and the mesentery is kind of connected wrong. The incidence is in 1 to 4 births. The most characteristic symptom is abdominal pain. So the infant will be really colicky. They're going to have these like red currant jelly stools. They might have some vomiting, fever, dehydration, abdominal distension. They might have, you might notice that they're grunting because they have some pain. So diagnostics, they're going to find like, it's going to be like a sausage-shaped mass in the upper right quadrant. This is called Danka's sign. And they're palpating the abdomen. So nursing care for this patient, they'll use a barium or air enema to diagnose and treat it. So nursing care, the patient will need to be NPO. Before surgery, they'll have to have a NG tube. Make sure that you're watching fluid and electrolytes. Watch for symptoms of peritonitis and shock. So when the infant has a spontaneous passing of stool, that indicates resolution of the obstruction. So malrotation and volvulus. So this is an abnormal rotation of the intestine around the superior mesenteric artery, and this happens in fetal development. So the major symptom is like a bile or green vomit. The patient might have some abdominal distension, abdominal pain. They might have GI bleeding, dehydration, lethargy. But really watch for those bloody stools, because that can suggest some ischemia or that the bowel has been like necrotic. So, again, the complications can be shock, so watch for tachycardia, tachypnea, hypotension, cool, clammy, cyanotic skin. So nursing care, surgical treatment is needed, where they do anastomosis. So potential complication from surgery is short bowel syndrome. So pre-op, your nursing care is initiating an IV for hydration and balance of fluid and electrolytes. The patient's going to need to be hooked up to NG. You're going to want to give an antibiotic. Inflammatory diseases. So, irritable bowel syndrome. So, the signs and symptoms are abdominal pain, they may have a lot of gas, bloating, an alteration of constipation to diarrhea, headache, nausea. You may find that their stools are really mucousy, that they've had some weight loss, anorexia. So, the nursing care, you're going to want to make sure that you're discovering, what triggers the irritable bowel syndrome. The patient needs to drink plenty of fluids. You want to promote regular bowel elimination. So, inflammatory bowel disease, there's two types. There's Crohn's disease, ulcerative colitis. So, Crohn's disease. Crohn's is an inflammatory bowel disease that's chronic. They're going to have periods of exacerbation and periods of remission. It can affect any portion of the GI tract, and they may have some areas that are normal healthy bowel, followed by some areas that are affected by the Crohn's. A lot of times it's the small bowel that is affected. So some of the signs and symptoms: abdominal pain, diarrhea, anorexia, weight loss. And really the clinical presentation is going to depend on the severity, like how much of the colon is involved. They might also have some, like a fever, growth delay, like a joint pain. They might have some inflammation of their mouth and lips and tongue. They'll develop those ulcers. They might end up having some kidney problems with developing kidney stones. And the diagnosis is based on history, physical, and then they'll draw some labs. So the patient will have like elevated sed rates, elevated C-reactive protein, and nursing care is to really control the disease. We want to prevent relapses, so the patient will be put on a corticosteroid to reduce inflammation. They'll be put on like Flagyl, Cipro as a combination. They can use other antibiotics like gentamicin, clindamycin. They might use some immunosuppressants. If the child doesn't respond to medications, then they may have to do surgery. but really make sure you're telling the parents that surgery is not gonna correct the Crohn's disease. Make sure you're providing emotional support. Ulcerative colitis. This is an acute or chronic inflammation of the colon. The patient's going to have recurring bloody diarrhea. The difference between Crohn's and ulcerative colitis is that ulcerative colitis affects like a continuous segment of the colon. The cause is unknown. They think that it might be due to genetics, but they're not sure. So the signs and symptoms, again, that bloody diarrhea, abdominal pain, they'll have fecal urgency, they might have some joint pain, chronic liver inflammation, skin lesions. So diagnosis based on H&P. They'll do like an abdominal ultrasound or x-ray. So nursing care. Again, disease control, we want to prevent relapses. So they'll use, again, steroids, immunosuppressant drugs. They'll make sure that the child's getting vitamins, natural foods. The diet should be high in protein and carbohydrates. I recommend an iron supplement. It's curable with surgery, so we'll do a proctocolectomy with an ileal pouch and an anal anastomosis. So appendicitis, this is inflammation of the appendix. Really our appendix is an organ that is not necessarily needed. The signs and symptoms, they're going to have vomiting, a lot of pain, they'll have that rebound tenderness over McBurney's point. So that's about 2 inches in from the right anterior superior iliac crest towards the umbilicus. And what they'll do is they'll do some deep palpation, and when they push in, the pain will be relieved, but then when they release again, then they'll have that severe abdominal pain. So the patient needs to be NPO for 24 hours. They'll have to undergo an appendectomy, so make sure you're doing wound care, pain control. They could do it laparoscopically, where the patient will only be in the hospital for maybe a day. So the appendix can become perforated before they remove it, and when this happens, the child's going to need to be on IV antibiotics, and they'll remain NPO with an NG tube in place until normal bowel function returns. Colitis. This is an infection of the umbilical stump. It's caused by strep or staph. The patient will have some redness and edema of the soft tissue around the umbilical stump. Diagnosis is cultures. So nursing care, prevention can be prevented through good perinatal care. The patient will get some IV antibiotics like Vanco or like a cephalosporin. So make sure that the parents know to keep the cord clean and dry. They can do cord care with like soap and water, alcohol, iodine. And the parents need to know that cord care usually needs to be done for 10 to 14 days before the total cord separation occurs. Meckel Diverticulum. So this happens during like the 7th to 8th week of gestation. And what happens is a fibrous band that they call the Meckel Diverticulum connects the small intestine to the umbilicus. It occurs in 1 to 4% of the population, more common in males. So the signs and symptoms are recognized in childhood. The patient will have some abdominal pain. They might have some painless rectal bleeding. Again, with that red Crohn jelly appearance. This needs to be treated though because the patient could develop anemia and shock from all that blood loss. So, nursing care. They'll have to do surgery to remove the diverticulum. Pre-op antibiotics will be administered. Again, initiation of IV fluids for fluid and electrolyte balance. Post-op, again, they'll need an NG tube. So, the functional GI conditions. Infantile colic. So, the cause is unknown. What happens is the patient's they're going to be really fussy, they're going to cry all the time. Usually occurs in infants younger than 3 months. You might see the infant pull both legs and arms into a flex position. Diagnosis is made on a report of the symptoms if they last for more than 3 weeks. So, nursing care, so conditions need to be ruled out. You're going to want to support the parents, really assure them, assess the feeding techniques, provide education. You can instruct the parents on how to calm the infant, like swaddling them, rocking them. Acute diarrhea. So this is excessive loss of fluid and electrolytes in the stool. So the signs and symptoms Again, the diarrhea. Make sure that nursing care, make sure that you're asking the caregiver about vomiting, any fever, pain, like how many wet diapers they've had in the last 24 hours. Diagnosis, they will do stool culture, you might take an electrolyte panel. So the nursing care, making sure that the patient stays hydrated. They might need some IV fluids. So chronic diarrhea. This is defined as one or more liquid stools for 14 days or longer. Signs and symptoms, again, are going to be the stools. They're going to have hyperactive bowel sounds, signs and symptoms of dehydration. So the nursing care is going to be, you're going to want to monitor for dehydration, treat the underlying cause. The infant might need TPN. So vomiting. Again, this is where the stomach contents come up through the mouth. Make sure that you're observing the emesis. If it's bloody, it's usually evidence of some sort of active bleeding. So make sure you're asking the caregiver again if there's like been fever, diarrhea, ear pain, headaches, and treatment, rehydration, bowel rest. The child might get like an antiemetic like Zofran or Reglan. Make sure that you're doing good oral hygiene. Cyclic vomiting syndrome. This occurs when there's recurrent spells of vomiting followed by periods of wellness. So again, the signs and symptoms is that period that lasts for 24 to 48 hours, and then the intervals occur usually every 2 to 4 weeks. The physician's going to want to rule out other conditions, but your role is supportive care, so like fluid replacement, reduce stress on the infant, making sure the environment is quiet, that you're comforting them. You can give some antiemetics. So constipation, this is when there's difficulty in passage of the stool, which will be hard. So again, the signs and symptoms, straining with stool. The stools will be hard. They may have a poor appetite. Diagnosis is based on the symptoms. So nursing care, you want to promote adequate intake of water. You want to promote foods high in fiber. The patient might need some fiber or stool softeners. You might have to do some bowel retraining. Encoparesis. This is stool incontinence beyond the age of 4. So the manifestations, you might notice that the child has problems with defecating, like it's really painful. You might have a lot of constipation, abdominal distension, tenderness, They'll have, of course, you know, soiling of their pants. So nursing care, you want to establish regular bowel habits. Again, high fiber, high water intake. Usually they'll avoid the laxatives. So gastroesophageal reflux. Signs and symptoms are vomiting and regurgitation. You might also notice some fussiness in the infant, weight loss, respiratory infection, vomiting. It becomes GERD when it persists beyond 18 months. So diagnosis is through history and physical exam. So you're going to want to provide caregiver support. Sometimes you can thicken the feedings, and then that will provide more caloric support, but not giving them as much food. Make sure that the infant is in an upright position after feeding. And if you lay the infant on their right side after it promotes gastric emptying. The patient could get a proton pump inhibitor or an H2 inhibitor, or they could do surgery. Hirschsprung disease. So this is a congenital disease. It's limited to the distal colon. They're going to have an absence of ganglion cells. So they're going to have a lack of stimulation to that portion of the colon. So they'll have an absence of peristalsis there. So the signs and symptoms will be failure to pass that meconium within the first 48 hours of life. They'll have some failure to thrive, poor feeding, chronic constipation. Oftentimes you'll see this in patients with Down syndrome. They may have some vomiting, abdominal obstruction. When the stool comes out, it might be ribbon shaped, and it'll be really foul smelling. So nursing care, they will need surgical treatment. The child preoperatively will be NPO and have an NG tube inserted. They'll need some IV fluids. And post-op, again, maintaining the NG tube, INO. The patient will have a temporary colostomy, so again, making sure that you're teaching the parents about good skin care. Lactose intolerance. This is the inability to digest milk and some dairy products. The patient will have symptoms of bloating, cramping, abdominal pain. They might be really gassy, have some diarrhea, and diagnosis is going to be based on history, physical, and then the physician will eliminate lactose from the diet and see if that works for the patient, if the symptoms are alleviated. So they'll eliminate dairy products and replace that. They can take enzyme tablets like lactate. And the enzyme can be added to milk or sprinkled on dairy products, and that reduces the symptoms. Again, making sure you're doing good dietary education and teaching the parents how to read food labels. So there's a lot of hidden sources of lactose. So celiac disease. This is a gluten insensitivity. So the signs and symptoms are going to be anorexia, weight loss, irritability. They'll get some diarrhea, abdominal distension. The diarrhea will be really foul smelling and kind of like a putty color because they're going to have all this undigested fat. So the diagnosis will be through a small bowel biopsy. So the patient will need to be on a gluten-free diet. Gluten is found in wheat, rye, barley, oats. So again, instruct about the gluten-free diet, how to read food labels. But nowadays there's whole sections of grocery stores that are gluten-free, so it's becoming easier to identify which foods are okay. So short bowel syndrome. This is a malabsorptive disorder. So the patients will have compromised bowel function. The signs and symptoms will be malnutrition and diarrhea. So diagnosis is by abdominal x-ray or ultrasound. A CBC might show anemia. So nursing care, you want to prevent complications. The patient might need TPN. So make sure you're monitoring that therapy. Monitoring INO. So hepatic disorders. So biliary atresia. This is a progressive inflammatory process of the bile duct. And there'll be fibrosis and obstruction. The most earliest clinical manifestation will be jaundice. The urine will be dark. It'll stain the infant's diaper. The stools will be like a tan clay color. They might have some hepatomegaly, splenomegaly. And diagnosis is the outcome is better if the infants have surgery in the first 60 days. They'll do liver enzymes, CBC, electrolytes. They'll do a torch titer, and that looks for antibodies for plasmosis, rubella, cytomegalovirus, herpes. So nursing care. So again, surgical resection, where they're going to correct the obstruction and provide drainage of the bile from the liver into the intestines. You're going to want to focus on good nutritional support, education of the surgery, make sure that that your, again, initiation of IV fluids, to prevent any fluid and electrolyte imbalances. So the patient will have an ostomy. So make sure again you're educating the family on how to manage the stoma, what a healthy stoma should look like, good skin care, making sure that there's no skin breakdown around the stoma. The patient might have some itching. Watch for GI bleeding, ascites. So cirrhosis. So what will happen with this condition is there'll be an inflammatory condition of the liver, usually from like a chronic hepatitis. It leads to fibrosis and liver disease, which then causes the cirrhosis. So there'll be irreversible damage to the liver. Again, the signs and symptoms are going to be jaundice, growth failure, muscle weakness. They might have some portal hypertension, splenomegaly. Diagnosis is going to be based on history, physical. They might do a Doppler ultrasound. They'll do liver function tests. So your nursing care, you want to prevent and treat complications. There's no successful treatment of cirrhosis. So you want to manage those malabsorption problems. So the patient will have to be on a low-fat, low-protein diet. They'll need supplemental fat-soluble vitamins. They'll be on a fluid restriction, some diuretics, low-sodium diet. They might need a blood transfusion. They'll need a liver transplant. So hepatitis. So this can be acute or chronic, and again, inflammation of the liver. It can be caused by a viral or bacterial infection. So the signs and symptoms will be headache, anorexia, malaise, abdominal pain, nausea, vomiting. They're going to have those clay-colored stools. If they're in the icteric stage. Diagnosis is going to be based on history of exposure, symptoms, and they're going to do markers specifically for Hep A, B, and C. They'll do liver function tests, and what they'll see is that the patient will have an elevation of their ALT and their AST. They may do a liver biopsy. And nursing care, so you're going to want to educate about prevention. You're going to want to provide rest of the liver, adequate hydration, adequate nutrition, so prevent that dehydration. The patient can get an immune globulin. If the patient has hepatitis A, usually the prognosis is pretty good. You're going to want to, again, just manage those symptoms, have the child rest. The family's going to need to be instructed on how to administer medications. Make sure that, there's a vaccine for Hep A and Hep B, so promoting those vaccinations. So abdominal trauma, it's the leading cause of death in children and adolescents. Caused by injuries, motor vehicle injuries are the primary cause. So the injuries can be to the abdomen, the spleen, the liver, pancreas, intestines.